Good afternoon. My topic for today is Paediatrics and TIVA. Now, TIVA is the maintenance of general anesthesia by the intravenous infusion of anesthesia drugs. Due to the understanding of the favorable pharmacokinetic and pharmacodynamic properties of propofol and the availability of short-acting opioids, TIVA is gaining popularity amongst pediatric anesthesiologists. It has many benefits in children. It provides a smooth, pleasant induction of anesthesia. There's a reduction in airway reactivity, laryngospasm, and bronchospasm. There's a reduction in postoperative nausea, vomiting, and immediate delirium. This translates into increased patient comfort and parental satisfaction postoperatively, and also helps to avoid environmental pollution. But we're always concerned whether we should use TIVA in children. And the first thing that comes to mind when you think of propofol is propofol infusion syndrome. Now, in this, a large lipid load inhibits the complexes in the electron transport chain, leading to interference with the mitochondrial energy production and resulting in rhabdomyolysis, acidemia, and multi-organ failure. However, this is very rare, although it is potentially fatal. This can recover if the child is being monitored continuously and the infusion is stopped in time. The risk factors for developing propofol infusion syndrome include a propofol infusion of more than 4 mg per kg per hour for 48 hours, critical illness, low sugar intake, the co-administration of catecholamines and steroids, and underlying metabolic disorders. So as you can understand, this is likely very rare under anesthesia. The other problem that we are worried about is the fear of the risk of awareness. I can't monitor the plasma levels of drugs. Supposing the pump malfunctions, what are the tissue cannula tissues? These are all the thoughts that come into our minds. The National Audit Project NAPS 5 in UK studied the incidence of accidental awareness under GA in 2014. They studied 2.8 million GAs, of which there was 141 cases of accidental awareness under anesthesia, which involved 8 children. Of these, only 1 child had received TIVA. The other problems that come to mind when considering TIVA is the difficulty in securing the IV access, pain on injection with propofol, the great pharmacokinetic and pharmacodynamic inter-individual variability in neonates and small children, the requirement of specialized equipments, and the cost of disposables like infusion lines, etc., and the environmental effects of the plastic waste that are generated. Now, TIVA may become mandatory when volatiles are unavailable, like in remote anesthesia or patient transfer, when volatiles are contraindicated, if inhalation delivery is not possible, as during airway surgery, bronchoscopy, etc., when there's a risk of malignant hyperpyrexia, in children with muscular dystrophies, and when neurophysiological monitoring is required during spinal surgery. TIVA may be especially beneficial in surgeries associated with high risk of postoperative nausea, vomiting, or a child with a history of severe postoperative nausea, vomiting, in children with URTI or reactive airway disease fear of face masks, high risk of emergent delirium or past history of emergent delirium, in airway and ENT surgery to reduce airway-related complications like laryngospasm and bronchospasm, which all anesthesiologists are so scared of, and in children with raised ICP or neurosurgery. TIVA may be optional for teaching of trainees and to maintain skills in use of TIVA, so we should all practice TIVA on and off so that we can use it when we really require it. We should not consider use of propofol-based TIVA when there is significant cardiac dysfunction, when there's any shock, propofol allergy, in children at increased risk of developing BRIS, or when there's mitochondrial dysfunction, and of course when equipment is not available. Now, pharmacokinetics is important to understand how IV drugs behave in the body, and pharmacokinetics studies the distribution, metabolism, and elimination of a drug in the body, and a pharmacokinetic model is nothing but the mathematical representation of the same. Now, the pharmacokinetic behavior of most anesthetic drugs used for TIVA can be predicted with a 3-compartment model. In this, whenever a bolus of a drug is given, it enters a central compartment of V1. From V1, the drug distributes to other compartments like the rapidly accumulating compartment V2, which is composed of highly perfused organs, and the slowly accumulating compartment V3, which is composed of poorly perfused organs. From the central compartment, the drug also acts upon the effect site, which in the case of anesthetic drugs is the brain, and it is from the central compartment that the drug returns to, and then it is metabolized and eliminated from the central compartment. Now, whenever a bolus of a drug is given, there is a sharp rise in the plasma concentration, and this is followed by a sharp fall as the drug gets distributed to the peripheral compartments and then is metabolized and ultimately it is cleared from the body. So when we are considering giving TIVA, if we give just an IV bolus of a drug, there will be a rapid rise, as you can see in the dotted line showing the rapid fall, which I just described to you. If you don't give a bolus and you start an infusion, then as you can see, there's a very slow rise in the plasma drug concentration levels, and it takes almost 5 half-lives to attain the therapeutic plasma drug concentrations. So what should we do? So the ideal thing to do is to give a drug bolus to achieve the plasma concentrations that are desired and maintain those concentrations with the use of a maintenance infusion. And this has been called the Dept infusion scheme for TIVA, or the Bolus Elimination-Transfer scheme, in which a drug bolus is given to fill the central compartment V1, and then a maintenance infusion is given in order to replace a drug which is lost from the body by transfer to the other compartments or by elimination from the body. When we are giving TIVA, it is important to remember that the pharmacokinetics of drugs are different in children as compared to adults. Children have a larger volume of the central compartment V1, hence they require a larger propofol bolus in order to attain therapeutic plasma concentrations, and they require larger initial infusion rates. They also have larger volumes of the peripheral compartments B2 and B3, so they require larger initial infusion rates in order to saturate these compartments. And also it is important in the time of recovery that because these compartments are larger size, there will be a redistribution of the drug back into V1 when the infusion is stopped. This translates into a longer context-sensitive half-life and a slower recovery in children. Children also have higher clearance rates, so they require higher maintenance infusions. But this is not the same in all the age groups. In neonates, there are much lower clearance rates because the organs are not fully mature, so they require lower maintenance infusions. And in some neonates, ex-premature infants with critically ill children, there may be a markedly slow and altered metabolism and a marked pharmacokinetic variability in the disposition of intravenous drugs. So in these children, TIVA may be avoided, or if necessary, it should be used with great caution. Now, TIVA can thus be administered either by a manual dosing using a single drug or a combination of drugs, by intermittent boluses of a single drug or a combination of drugs, by a fixed rate infusion using an IV drip set or a syringe infusion pump, or infusions based on a manual algorithm, which are much more scientific way of giving it. The second way of giving TIVA can be use of a target controlled infusion or a TCI. And a third way, which is the most sophisticated way, will be by closed loop administration of intravenous drugs. In this technique, the drug infusion is titrated against a measurable feedback signal, which might be BIS, BP, heart rate, etc. And this completes a feedback loop and directs the administration of the drug. Now, we are all familiar with the manual infusion scheme for propofol in adults, which has been called the Roberts or the Bristol regime, or the 10-8-6 regimen. In this, following a bolus loading dose of 1 milligram per kg, propofol infusion is given at 10 milligram per kg per hour for 10 minutes, 8 milligram per kg per hour for another 10 minutes, and thereafter 6 milligram per kg per hour. And this attains a plasma propofol concentration of about 3 microgram per ml, which is adequate for many more surgical procedures, as you can see in the blue line. However, the brick colored line is showing the propofol levels in a child, and as you can see in the child, the plasma concentrations using this propofol infusion regime attained are very low or subtherapeutic, and it has been found that children require almost 2 times the initial doses of propofol as compared to adults. So 2 popular manual pediatric infusion schemes have been subsequently developed. This is the Macfarlan regime for children aged 3 to 11 years and the Stewart regime for children aged less than equal to 3 years. The Macfarlan manual infusion scheme for children targets a propofol plasma concentration of 3 micrograms per ml and is used in children aged 3 to 11 years. As you can see in this, induction dose is much higher as compared to the earlier regime I showed you, which is 2.5 milligram per kg. For the first 15 minutes, 15 milligram per kg per hour is given, followed by 13, 11, 10, and then after 2 hours, it is maintained at 9 milligram per kg per hour. In the Stewart regime, which is for smaller children aged less than equal to 3 years, the induction dose is much higher, varying between 3 to 5 milligram per kg. And then the higher rates are given initially, followed by lower maintenance infusion rates after the first 1.5 hours or so. Now, the other way of giving TIVA is by use of a target controlled infusion. In a target controlled or TCI system, a controlled infusion is delivered to achieve a user-defined target drug concentration in the plasma or the effect site. In the case of anesthesia, the effect site means the brain. However, in the pediatrics, only plasma targeting is being used. The TCI system is supplied with preloaded and activated pharmacokinetic parameter sets, or propofol, anaesthetic, etc. And the TCI system calculates the bolus dose infusion rate to maintain the selected target drug concentration. So the components of the TCI system include an infusion pump, which delivers initial bolus and the subsequent infusion rates, microprocessors, which have pharmacokinetic software, and they determine the delivery rate, visual and audible safety systems, alarms, and a user interface. Here you can see to select the drug, the pharmacokinetic model, the patient characteristics like the body weight, age, sex, height, etc., and the target plasma concentration, which is set by the user or by yourself. Now, the pharmacokinetic models in children are very limited at the present time. For Propofol, there are only 2 widely available and validated pediatric pharmacokinetic models. The first is the Cataria model, which is for children aged 3 to 16 years and weighing 15 to 61 kilograms, and the Ped model for children aged 1 to 16 years, weighing 5 to 61 kilograms. For larger children weighing more than 61 kilos, the Marsh adult model can be used. Other pediatric models under evaluation for use in pediatrics are the Short, the Shuttler, and the Eleville general purpose models. For remifentanil, only one pharmacokinetic model is available called the Minto model, and in children it can be used if the child is more than 12 years of age, weighs more than 30 kilos, and has a height of more than 1.3 meters. So this you can see is a TCI pump in which this is offering the Schneider, Cataria, Ped, Marsh, and Minto models, which can be selected by the user. Now, when we are giving propofol-based TIVA, we must use certain adjuncts. This is given in order to improve the surgical conditions, to reduce the hemodynamic response to surgical stimulus, to lower the propofol target concentrations, and hence reduce the side effects of propofol like bradycardia and hypertension. The common adjuncts used in propofol, the most common is remifentanil. We all know about this, we've read about it. It's an ultra fast-acting opioid with a very short context, insensitive half-life. When I say insensitive, it means that the recovery time or the duration of the context-sensitive half-time is irrespective or is not dependent upon the duration of the infusion. So for however long you give the infusion, the child will recover from fentanyl within 3 to 4 minutes. This has been found to reduce the propofol requirements by up to 50%. For smaller children, manual infusions have to be used. In larger children, the Minto model can be used. And the co-administration of propofol and remifentanil by target control infusion constitutes ideal TIVA. Another common drug is ketamine. It can be used as a sole anesthetic agent for TIVA where the resources are limited or when propofol-based TIVA is unsuitable. The manual infusion rates for ketamine vary from 0.1 to 2.5 milligram per kg per hour, depending upon which drugs you are using it along with and what is the surgical procedure which is being done. It has a specific disadvantage for use in TIVA. It interferes with processed EEG monitoring. Now, ketofol is a combination of ketamine and propofol, and this has been widely used in the outpatient department and for procedural sedation. Another common adjuvant nowadays is dexmedetomidine. It is an alpha-2 agonist. It also causes hypotension and bradycardia. It should be used cautiously when used along with propofol. It also has a long context-sensitive half-time, and it should be stopped well before the surgery ends so that the child wakes up in time. Other opioids can be used like fentanyl and alfentanil. Neuromuscular blocking drugs can also be used in order to improve the surgical conditions. But remember that they do not reduce the propofol requirements. In fact, they may increase the risk of awareness during TIVA. So processed EEG must be used whenever you are using neuromuscular blocking drugs during TIVA. Other drugs are midazolam, clonidine. Another very, very important thing to use, an adjunct to be used during TIVA is the use of a peripheral nerve block or neuraxial techniques. They are immensely beneficial in reducing the propofol requirement and hence the side effects of propofol. So when you're conducting TIVA, the drugs, the programming of the pump, the infusion sets, etc., should be checked before starting. And then the next thing to do is how do I establish IV access in this child? Will I be able to secure IV access before induction? That this will depend upon the age of the child, the indication for the TIVA, whether the child is cooperative, whether IV access is likely to be difficult, and whether there are any comorbidities related to the airway and the cardiorespiratory systems. Various strategies can be used in order to secure the IV access. This include non-pharmacological strategies and pharmacological means to secure IV access. Once IV access has been secured, the next concern is the reduction of propofol injection pain. For this, one can select a larger vein, a large proximal vein or antecubital vein can be selected. Pre-treatment can be done with IV lignocaine, opioids, ketamine, or pre-treatment lignocaine can be done along with venous occlusion, or a lignocaine propofol mixture can be used, or nitrous oxide can be used to facilitate decrease the pain. If, however, an IV line cannot be secured, then an IV access may be obtained after inhalation induction and then one can switch over to TIVA. This is obviously very unsuitable and cannot be done if the volatiles are absolutely contraindicated. And the other concern is the care during transition to TIVA care should be taken during transitioning from TIVA. There's a risk of both under and overdosing of propofol during this time. Now, once the IV line has been secured, we must take care to prevent problems associated with drug delivery. The IV infusion must be kept patent and viable at all times. The IV cannula must be visible. An anti-reflux valve should be used. A multi-lumen extension set should be used. There should be minimal dead space volume, and the dead space in the system must be flushed at the end of the case. We must also ensure that the equipment is functioning properly. For this, all pumps should be programmed and should be functioning correctly. The correct drug should be loaded in the correct pump with the correct drug concentration. Dilute drug concentrations should be used, and pressure alarm should be set on the pump in case the cannula tissues. The drug delivery can also be checked by checking the effect of the TIVA continually, by process EEG monitoring, by monitoring the vitals like blood pressure and heart rate, and by clinical monitoring of the patient's responses and any movement in response to surgical stimulus. So during the clinical conduct of TIVA, induction can be done with the intravenous propofol bolus, which can be delivered manually by variable rate infusion or by a TCI pump, and the plasma target concentration is usually set at around 4 to 6 micrograms per ml at this time. If IV access cannot be secured, inhalation induction can be done, and this can be followed by an IV bolus of propofol of 1 milligram per kg, which is lower than which is normally used. And the plasma target of propofol can be kept a little bit lower until the inhalation agent is washed out of the body. This can be titrated to the clinical response and the processed EEG. The airway during TIVA can be secured using endotracheal tube or a suprachoroidal device depending upon the type of surgery. Neuromuscular relaxant blockers can be given after the induction of anesthesia, and it has been found that a target plasma remifentanil concentration of 2 to 3 nanogram per ml and a target plasma propofol concentration of 3 to 4 microgram per ml can upturn the intubation response. For maintenance of anesthesia, the propofol target is usually set at 4 to 6 micrograms per ml. If a regional block or an adjunct is given, it can be reduced to 4 microgram per ml. If a regional block and remifentanil or any other adjuvant is given, it can be reduced further to 2.5 micrograms per ml. Various remifentanil targets have been suggested in the literature. If it's a minor surgery and spontaneous respiration is required to be preserved, then lower plasma concentrations are desired and lower infusion rates can be used. If it's a major surgery and IPV is going to be given, then one can use a higher plasma, one can target a higher plasma concentration of remifentanil, and a higher infusion rate of remifentanil can be used. Remembering all the time that there is a great inter-individual variability to the response of drugs in children, and the concentration required depends upon the status of the child, the age, the whether the child is obese or small or large for age, co-administration of other drugs, the degree of surgical stimulus, and gender, ethnic, and racial differences should also be taken into account. All infusions should be titrated to clinical signs of depth of anesthesia, vital signs like heart rate and blood pressure, and processed EEG or BIS monitoring. Thus, monitoring during TIVA is very important. Vitals should be monitored. Clinical monitoring must be continuously done. And effect site monitoring can be done using processed EEG. And the target value for BIS in children is similar to that in adults, and it should be kept between 40 to 60. So processed EEG must be used in all children more than 1 year of age, and especially when using neuromuscular blocking drugs. There are some problems of processed EEG in the pediatric age group because all the algorithms are based upon adult EEG data. It is unreliable in children less than 1 year of age. There might be some latency and electrical interference. Abnormal patterns may be obtained in children with developmental delay or cerebral palsy, and it has been found also that the anesthetic requirement is greatly reduced in children who have cognitive impairment. However, processed EEG monitoring has got undoubted benefits. It helps to guide the TCI of the manual infusion rates. It also serves as a disconnection monitor for TIVA. If suddenly you find that your BIS values start rising, then you know that the drug infusion has got interrupted or the cannula has extravasating, and you can immediately address the problem. During recovery, children take longer to awaken as compared to adults. So this is due to the larger size of peripheral compartments, leading to a higher context-sensitive half-time. Most children awaken at an estimated plasma propofol concentration of 1.2 to 1.8 microgram per ml. If one is using remifentanil for TIVA, must give a long-acting analgesic like morphine 40 minutes before stopping remifentanil in order to prevent hyperalgesia and acute opioid tolerance. In order to avoid prolonged recovery, you must reduce the propofol infusion rates early, use regional or peripheral nerve blocks, use adjuvant drugs, and use processed EEG monitoring. In the future, TIVA may supersede inhalation anesthesia and pediatric anesthesia practice. Point-of-care propofol assay using either breath or plasma analysis is under investigation. Specific neonatal algorithms for processed EEG anesthesia depth monitors and pediatric pharmacokinetic models are being delivered. The ultimate aim of TIVA will be to formulate closed-loop controlled intravenous drug delivery by use of closed-loop anesthesia delivery system CLADS and automated total intravenous anesthesia or TIVA. Thus, TIVA with propofol in children has got distinct advantages. All anesthesiologists should be aware of the indications and the contraindications of propofol-based TIVA in children, and should be aware of the pharmacokinetic and the pharmacokinetic differences between adults and children. As in adults, standard safe TIVA practices should be used for ensuring appropriate drug delivery to patients, and these can be read in the guidelines for the safe practice of TIVA by the Association of Anaesthetists and Society of Intravenous Anesthesia, available at this link. Thank you very much for your patient hearing.